Good morning, how are you? We're about to go into full-blown summer this week. It's still only June, but we've got 4 days of temperatures exceeding 30 degrees coming up. And not only that, it's the second sort of so-called heat wave that we've had. Look at my fence. My hedge needs a right trim. Everything needs cutting. So, I've got a full day at work today. It's my usual Monday 9:15 to 2 or 1:30, and then same on Tuesday, and then Wednesday we had off, and then only because we haven't got enough patients to fill it up, and then Thursday we're more or less working a full day today, and then Friday tomorrow just the morning as usual. So I can't complain about my life, and I can't complain about the fact that we are actually paying the bills at the moment, so that's good. We're not making anything like the sort of profit that younger dentists might need to make and want to make and have to make, but we're doing some excellent work, real high quality technically work that you probably would only do if you got 30-40 years of experience in the profession. We've got one lovely lady who's wants to have a new appearance, nice looking teeth. She's got a fractured upper left incisor, post-retained crown. The root is what's fractured, not the crown. So we're going to do some crowns on the top right, a 6-unit bridge across the front, 3 to 3, AAPPAA, and then some 3 crowns I think on the left. So because she has problems keeping her mouth open, we're going to split it up into 3 jobs. Normally, it's always tempting to think you can do 10 crowns in one sitting. And having worked in Harley Street and seen people have multiple crowns done in one fitting like that, then, but I'm not, it's more sensible and more comfortable for the patient to plan it in 3 separate jobs in effect. And the technicians will have no trouble matching the colour and linking it all up. So the only trouble was we were going to take out the upper right for the 5 and the 5 and the 6 anyway. The 4's already a post-retained crown, so we were going to take out the 5 root and the 6 root. Well, the 5 was a root and it had a periapical bone loss, and the 6 was root treated but not brilliantly. So, because she doesn't want to wear a denture, we root treated the upper right 5. So that went very well, and we managed to root treat it all right. But she's got an unresolved gumboil buckle to the upper right 5. So we used a trick which I learned years ago, which is very, very reliable, and that is you get the area, put a spot of local anaesthetic in the area, and then get a small GP point, something like a 30, and gently push it into the gumboil. And she wants to have a new look, so we've going to do some crowns in 3 batches: top right, centre and top left. And on the upper front she's got a broken root with a post-supported crown in. So I'm going to do a 6-unit bridge across the front, 3 2 1 1 2 3, and then on the top right we've had to root treat the 5, but the gumboil on the 5 hasn't gone away, so I'm going to have a look and see if possibly there isn't another root in the 5. And then on the top left there's just a few random crowns to do to complete the look. So the upper right 6 is root treated, not brilliantly, but no periapical rarefaction, no bone loss. So we're going to do post-supported crowns on the upper right 5 and 6, and the replace the post-supported crown on the upper right 4, then a 6-unit bridge, and then 2 or 3 crowns on the upper left. And that'll take the best part, I don't know, of a month or 2 even to do all that lot, because and then the problem with these jobs is that obviously the patient wants everything done quickly. I mean, always, as quickly and easily as possible, and you have to sometimes say to them, look, you're paying several £1,000s for this. It's not like a 5-minute job. It's probably one of the most complex and technically difficult jobs and time-consuming jobs we do, requiring a lot of clinical skill. And but she's okay, providing we keep the visits manageable, and I'd say just about an hour and a half, including finishing up and putting everything back. So one trick which I learned, which is useful, I'll pass on, which is that when you've got an unresolved gumboil, or even a gumboil where you're not at all sure which tooth it's coming from, you put a drop of local anaesthetic in the buckle, adjacent to it, and then take a small GP point, accessory point, or accessory point, or a 30 point or something, and then don't jam it straight in because it'll be too hard initially. Just gently introduce it into the canal, into the gumboil, and what it'll do is that if you're, if you wait a little bit for the heat of the gum to warm it up, and you're pretty sensitive as to how you're poking it in, it'll trace the path of the infection. And then what you do is you just, if there's a big excess still, snip off most of the excess. Don't forget you're going to want to get it back out again, and take the patient through, take a periapical x-ray. She was all over the place, wasn't she? And too busy picking her nose to steer the car. And then what will happen is, on the x-ray you'll see that the GP point will point towards the tooth, which is the offending tooth, which in this case was still definitely the 5. So we're going to have to look for another canal on the 5 there. But the point I'm sort of I want to make is that, the patient's dead keen to get this done. You're dead keen to get this. In this case, we've already taken the money, so there's less pressure on me to rush things. But obviously there is pressure on me to get this thing finished and move on to the next job with another happy patient. So what I'd love to do is having done all the preparation for all the posts on the upper right 5 and 6, and also the 4, because we've taken the post-supported crown out the 4, is to just take a mould and get on with making those crowns. But I'm running out of fuel. But I can't fit those crowns until that gumboil's gone, and I won't. And fortunately, we've got a fallback position insofar as if in the unlikely event that we do have to take the 5 out, I can then still do a bridge from the 4 to the 6. And you might argue that might even still be a better idea, but I'd rather do 3 crowns if I can. So that was, so that's the sort of the biggest job we've got on at the moment. Other than that, it's mostly checkups. We were very slack about a month ago. Now I'm pleased to say things have sort of livened up a bit. I don't know why. I've always said it's the economy. People are more positive about things. They sort of tend to get on with all the things that they need to get sorted, including their teeth. We've got a lot of patients coming in who've got problems such as a loose tooth, which they know about, we know about, and they've finally decided they're going to have it out because it's giving them so much trouble. And then, this other guy who comes in every 2 years who needs a ton of work, and every time he comes in we tell him he needs a ton of work, and he always says, I'll discuss it with my wife. So and it costs us a lot of money because he very rarely, he has had some stuff done, And he's got 3 implants in his mouth. So I mean, in the past he has had some advanced work done, but he's just immune to any sort of entreaties as to cutting back sugar in his diet. Being in his late 50s and still, like for example, got mesial and distal cavities on his upper right 3. So he's intractable in terms of prevention, and he's pretty intractable in terms of treatment as well. The number of treatment plans I've spent 20 minutes over for him, just trying to give him some sort of plan. Now, what do you do in a case like that? Well, let me just get out of the junction of death. What you do is, if you get the sense that the patient's sort of wasting your time by constantly asking you to what you can do, and then sort of going away and never coming back, not having it done, is you have to, I think, sort of broadly categorise them in. You have to sort of, in a way, you have to sort of call their bluff. You have to say, look, this is going one of 2 ways. You're either going to spend a load of money and time in a chair, and we're going to rebuild your teeth, in which case you'll have to look after them. Otherwise, in 4 or 5 years' time, they'll all be decayed again, and I'm not going to argue with you over whose fault that is. It'll be your fault. Or we're just going to go down the road to dentures. And you can say neither is any better than the other. I've seen loads of patients who've done both, or either. And it's an honourable path, and it's the only path for some people. So, and what happens is you get to the point where what you're really doing is you're really saying to the patient, look, I think we've got to the point in your life where you're going to need dentures. And for someone who's sort of only in their late 50s and has sort of really never had any trouble chewing and eating stuff and with their appearance, really, or not really bothered much about their appearance, missing teeth and that, and had gums, roots that are rotten down to the gum, but then really haven't sort of given them any trouble, etc., etc. To be told, okay, right, we've reached the denture stage now. Anytime you have trouble, we'll make you some dentures, and then whenever you lose a tooth, we'll just take it out and add it on your denture. And I always say to them, you don't have to worry. Once you've got some dentures, you don't have to keep having them made. You can just, if you lose another tooth, just have it added on the denture. We don't have to pay for it all again. And they're not thinking, oh, that's brilliant. I can have dentures. I can have teeth in under. They're thinking, oh my God, here I am at the point in my life where I'm going to need dentures. Now, the problem is that, as I say, I've done this to this guy many, many times, and he's not at all a fan of having dentistry done, going to the dentist. I think his wife tends to drag him along. Whenever I start trying to discuss options with him, he's very much sort of, well, you'll have to discuss it with my wife. Send the estimate to my wife. Discuss costings with my wife, etc. So he's not really. He's trying to remain disengaged. Like a lot of men do, like they ignore a problem by trying to remain disengaged from it. And I think the only thing, with hindsight, the only thing that I did wrong was I was talking too much. I was overselling it, right? You get to the point where you're like, okay, I don't mind. If you're keen to keep your teeth, I'll make you up another big long treatment plan. We could still do quite a lot of work to your teeth. Normally, if somebody walked in with a set of teeth like this, I probably wouldn't be giving them like a big treatment plan with crowns and stuff on. But because it's you and I know you a long time, I'm prepared to do that. And then what happens afterwards? I thought to myself, you were really overselling that. You were making it look like you wanted to do the work. That there's such a big financial incentive in that amount of work that. So in the end, I mean, I've managed to get him to agree to have his front 2 teeth crowned. Both, one of the upper left one is root treated and needs a post crown, and the upper right one is not root treated, but is had a large distal incisal composite, which is now missing and is decayed underneath and will need root treating and a post crown. So we've got 1 root treatment and 2 post crowns out of the 2 front teeth, on the understanding that probably we're not going to do anything else about anything else. All the rotten roots and stuff at the back, decay at the back. So now you might say, well, that's a win. You know, you've got probably over £1,000 worth of treatment out of that bloke, and he's going to have his 2 front teeth back, which is what he wants from appearance purposes. But it's, you know, it's not a solution, is it? Well, it's not a solution one way or the other. It's just like a piecemeal solution. It's just a partial solution. But it's going to solve his problem, which is that he's walking around with a fractured upper right central incisor, which looks terrible. But I think, you know, sometimes you have to just draw a line underneath it and say, I've got a few patients where I've just got a note saying basic treatment only, because, you know, you're at first, you know, perhaps they will never ever, you know, they won't brush their teeth properly, or despite several attempts, or they're very, very difficult to treat. For example, they are like, I wouldn't say not very nervous, it's not necessarily an obstacle, but just can't keep their mouth open, or make a load of saliva, or just generally try to you're just on a hide into nothing trying to do advanced treatment on them. And you're not obligated to do advanced treatment on everybody. I mean, you need to remember this. You're not, you know, my consdem in the early days said to me, you know, if someone comes in and you think they need a crown, the next thing you've got to ask yourself is, do they deserve a crown? Will they look after a crown? Well, is the crown going to enhance your reputation? Because if you do a crown on someone and it fails within a few years, they're going to go around saying, oh, I had a crown done at Angry's, and you know, it cost me 600, 700 quid, and it only lasted 2 years. And you'll be thinking, yeah, that's right, that's because you never brushed it. Or because you didn't stop eating sweets, you know, you had a bag of Polos in your glove box, etc. And there'll be, you know, your reputation will suffer as a result of this patient's non-compliance. So be careful. Don't just agree to everything. I know there's, in the old days of the piecework, there were under a lot of pressure to say, yes, we'll do stuff. But in the old days, the bar was lower, you know. The patient was, if you did something for a patient and, I don't know, they paid 60 quid for it or 80 quid for a crown or something, lasted a couple of years, they'd probably see that as reasonably good value for money, providing you were careful about what you told them. Because we still get patients in who say, you know, I went to see Mr. So-and-so, and he did me a crown 15 years ago, and now it's broken or something. And you know, he told me that it was going to be, that was it, you know, it was one and done, that I'd never need it redoing again. It was crowns. They think crowns are like the rest of life, the rest of your life. So you just have to be. But then what can you tell people about crowns? You know, I mean, the standard thing to tell them is that they last 10 years. Well, I mean, depends on the circumstances. They don't all last 10 years. And you certainly can't guarantee that they're going to last 10 years. And if someone came back with a failed crown after, say, 7 or 8 years, I don't think I would replace it for them free of charge. So you have to, you know, don't forget that you're working in good faith. You make a reasonable faith attempt to do a crown. because you think it's an option. You think it's one of the options open to the patient, and then you've got but then you're not guaranteeing it's going to work. You can replace stuff, given providing that you make it clear to the patient that their replacement is in full and final settlement of any potential claim they might have against you for the original failure. That is certainly doable, and I might advise you to have a word with your indemnity association before you do anything like that, because to be honest with you, they'd rather you just refuse and challenge the patient to sue you for negligence. But dentists don't do that, and I don't think they necessarily should do that. I think if something, we had a crown, this is a lovely lady, and we did her a crown, and I think ultimately just the prep was too short. We just didn't, it was a big old tooth, and the ratio of the size of the tooth to the depth of the prep was too low, was too high rather. And so the crown came off, and then she was really worried that she'd paid a lot of money for this crown and that she'd done something to it, and so said she was lovely. And I was like, no problem, just come in and we'll replace it for you free of charge, no questions asked. So we had. So there we go. So that's just two patients over the last week, which are sort of management. They're more management than dentistry, to be honest with you. I mean, anyone can do a post crown if they're a half competent dentist, but it's the examination, the treatment planning that is I think is the key. Starting off with this woman saying that she was going to need a denture, and then finding a way to to try and make sure that she doesn't. This job I'm doing for this 10 crown job, 3 post crowns, 6 unit bridge, I mean, it may be the last time I ever do a job this big, because I'm 67 now, so I don't know whether I will. It's not because I can't do it. I mean, I've got no problem with eyesight and hand-to-eye coordination, and my hands are steady as it ever was. So I've been lucky in that respect. But these jobs don't walk in every day. So, and I don't necessarily. It may come a time when I'm going to look at that and say, no, that needs to go off to some sort of specialist restorative guy, a younger guy, in the same way as if I have really difficult endo, we'll send it off to the endodontist, or certainly refer all the ortho, and we don't refer much perio. But anyway, it's a lovely day, and I don't mind being indoors today because for A, we got some more lovely weather coming, and B, I'm out in the sun enough anyway. I've got a decent tan already, so I don't really want to be lying on the beach in Margate. If I was, I'd have to be under a brolly with my factor 50 on. And really, what's the point? Mrs. Angry loves that. I don't love that. So as far as these podcasts go, I mean, obviously they're intermittent. I've always been honest. I only do them when I feel like doing them, so they're not done to any schedule. And I only do them when I've got something interesting to say. With me being the judge of what's interesting and what's not. So we've done a clinical thing today, and I have done a thing on the stupid under 16 media ban, which I don't think had anything clinical in it at all. But I've had a little bit of a you know, I'm too busy doing other stuff, taking the kids to school and that, to sit in the surgery and do post-production editing on these videos and upload them. Although it doesn't take long, but we're in the middle of a fee review as well, so so that has to take priority. But anyway, perhaps I'll get them uploaded this week, see how it goes. You'll know, I don't know, you know. How can you know something that I don't know that I'm going to do? It's weird, isn't it? It's a conundrum. Spooky. Right, I'm here now, so I'll say see you next time, and I hope you have a lovely day. Okay, bye.